Welcome back to our presentation on Inspired Caring, Transforming for Population Health. During the first part, you heard Mark talk about all the work we have done in transforming from the first curve to the second and in providing the right care to our patients and all the successes we have had. We couldn't do any of this without you, our employees, leaders, and providers. You are the culture of our organization. Now I want to talk with you about the work that we have focused on regarding our culture. Let's begin with 3 success factors. Okay, well, we have 3 success factors. The first one is the reform roadmap. Mark talked about this in the first part of the presentation, and we believe the work we've done here has aligned our transformation process and engaged all stakeholders, including governance and sponsor. It's extremely important to get everybody aligned on the same work. Second is leadership development. We all know leaders need to be the role models, and leaders are the ones that bring the employees along on the journey. So this work is very important. Our work has maximized the human capital of aspiring and established administrative, clinical, and physician leaders here at Holy Family Memorial. We've also worked to empower leaders at all levels. Most, though not all, can develop second curve competencies. And then last, of course, is the culture shaping work that we have done. We believe it has created an increasingly adaptable and achievement-oriented organization. Let's talk a little bit more about culture shaping. Those of you that have been with us since 2009 will recall at that time we chose to do a culture assessment to get a definition of our current culture. We brought in human synergistics from Michigan to give an assessment to our employees, to ask our employees, you, to define our current culture, but also to ask you to help us define the culture we needed in the future to be successful. As far as our current culture, that definition came out as very conventional, dependent, approval-oriented, a very hierarchical type of organization, and I'm sure many of you remember that. We weren't surprised by this definition, and we were also told by the organization that it was a very typical culture for a Christian healthcare organization who's been around for a long time. We also, as I said, asked you to help define our ideal culture. That definition came out as humanistic encouraging, self-actualizing, achievement-oriented, much more innovation and empowerment focused. We now had the culture that we were currently living in 2009 and our ideal culture with an obvious gap in between. So we needed to begin the work. The focus needed to be with our leaders. As we talked earlier, the importance of leadership development in any change process. We focused on increasing our leadership capacity in a variety of different ways. One was the intentional culture shaping. We just talked about that, and empowering employees to feel comfortable to step up and make decisions. Second, we worked on continuity and development of self, staff, and providers. Third, we looked at continuous renewal. That's really our SPUR process, where we evaluate what we do, how we do it, and if we feel we should continue to do it or not. If we want to continue to do it, then we take a look to see if we can do it more efficiently or effectively. And then lastly, we've also developed a number of learning partnerships. We have leaders that have been with us a long time. Experience is wonderful, but we also need outside eyes to help us see things differently. So we brought in some learning partners such as Creative Health, the Advisory Board, some of those type of organizations to give us that view as well. Our work to move from the current to our ideal culture began by focusing on leadership development. We understood they needed to live the ideal culture in order for us to get employees to do the same. We created Leadership Institute, a series of learning modules focused on our leadership competencies for our above and beyond leaders. We developed a leadership assessment ranking tool. We focused our leaders on developing themselves, their staff, and providers, along with creating continuity plans to sustain our work for the future. We hire an administrative fellow and intern annually from renowned schools to bring in outside eyes to our leadership staff. We have developed learning partnerships, as I talked about, with innovative businesses, and we have created leadership competencies and intolerables so it is clear what is expected of our leaders to go above and beyond and what actions and behaviors will not be accepted. We moved on to working with our employees. We started to think more about the why of what we are doing and found ways to talk about our internal pride in who we are and why we do what we are doing. We retold our story over and over again, even created a DVD to highlight the good things we are up to and to share a vision of our ideal culture and the same message with every employee. We are training all our employees in the art of productive conversations so that they feel more comfortable communicating with each other and with their leaders, even when the information is difficult or sensitive. We have developed a strong wellness program that helps employees stay healthy and focus on work-life balance. And we have created a robust accountability and recognition program that assures that our employees are living up to our ideal and expectations, and that those who do it really well are recognized for it. Leadership between the curves is challenging. First and second curve competencies are not the same. Through our assessments, we've determined that really only about 30% of our leaders are strong in both areas. This has been through some development, and obviously we need to continue to develop our leaders to move to the second curve competencies. This is what we refer to as the gap of the rear view mirror versus the headlights. The rear view mirror are the first curve competencies. We have many leaders who are competent in those competencies, and we're working to move to the second curve competencies, the headlights, and the work will continue. We've also been applying our change management to our leadership as well. In the last 10 years, we have reduced our senior leaders by 60% and our total full-time leaders by 28%. This leads to what we call addition by subtraction. As we know, when someone is in a position that isn't necessarily a good match, when you take them out of that role, the individuals around them are able to step up and do more. Addition by subtraction. You've also heard about more with less. Well, we believe in more through many. Again, in empowering employees to be a part of the decision-making process, we have many people in our leadership ranks. We have significantly enhanced physician and leader engagement and staff participation in change. This has been important for our organization. We have done a lot of work in culture shaping, both with employees and leaders, but we've also focused on the provider culture as well. So now I'm going to turn the presentation over to Dr. Amy Stockhausen to talk about provider culture.
Hello, I'm going to talk a little more about developing our provider culture. I never expected to be quoted, certainly not at national conferences. But when I was just getting started as the Associate Medical Director charged with cultural development, these words came out of my mouth, and they stuck. It's not just about finding people who are clinically excellent. It's also about finding people who are a good cultural fit for your organization and developing them as leaders in your organization. The need for financial and operational flexibility and efficiency mandates that physicians lead as well as practice. This was a voluntary survey that we performed at Holy Family. We did not mandate this survey in any way. If you ask me, getting 54% of providers to answer any volunteer survey is rather amazing, and these results are similar to or better to the national average, not normalized for networks of our size and type. And we know that based on some of the comments in the free text portion of the survey, these were not only our physician council members and staunch supporters who answered. The vast majority of our providers are engaged. In fact, our rate of active engagement is nearly 20% above the national average. And again, that is nationally, not norming for rural, small Catholic hospitals in cold climates. We're very proud of this. We've achieved our level of physician engagement in several ways, primarily through actively integrating our physicians in all levels of our network. On our board, 4 members of the board at any given time are physicians. In addition, the Physician Council is a committee of the board and reports to the board monthly. This keeps the board apprised on the workings and temperament of the physician group so that the board can use that information to assist with its future planning. The Physician Council functions as a liaison between the administration of the network, the board, and the physicians. It has taken an increasingly active role in strategic management of the physician group over the last several years. It has tackled physician cohesion and engagement, culture shaping of the physician group, physician leadership development, and some clinical integration strategies. It has become widely respected as a group that does something worthwhile, not just hears information, and also functions as a learning lab of sorts and a training ground for physicians who are interested in greater degrees of leadership. For example, we had twice as many people nominated for the open spots on the Physician Council this year than we had open spots. That tells you just how much this group is respected. The Associate Medical Director positions were created about 2 years ago to consolidate and formalize what 3 leading physicians were doing in our network, allowing them the time and the resources to support their efforts. These positions allow for more physician input at the strategic and operational level by physicians who hold both clinical experience and administrative goals in their hands. This makes physicians as leaders more visible, which is good role modeling for other physicians, and it has allowed for more on-the-ground time with these physicians than the CMO previously had time for. It functions as a more detailed learning lab for potential future network leaders and as succession planning for our higher leaders. The physician leadership concept was identified as an explicit goal by the Physician Council to help doctors understand that they are leaders whether or not they have an extra title. They are looked upon as leaders in their field, as well as in their individual departments, and their participation and behavior matter and have influence on those around them. We also have encouraged physicians to look at all clinical and non-clinical activities as potentially leadership, from directing patient care teams, to creating clinical pathways, to working on supply and chain improvement teams, to serving on the council or the board or whatever. And we'll talk a little bit more about the physician group cultural development on the next few slides. Our Physician Council decided to become a more active group, as I said, about 4 or 5 years ago. And with the assistance of one of our dynamic administrative directors, we developed yearly goals for ourselves with tactics and measures to keep ourselves on track. Initially, the goals centered on culture shaping of the physician group to integrate people, build relationships, and make the group more ready to work with administration at the hard tasks ahead. We then added leadership development as our next goal. What you see on the slide in front of you are examples of the goals that were created, not for you to really understand the detailed content of these 2 slides, but more for you to see the intentionality and the detail that went into creating them. In addition, the goals and tactics were tied conceptually to the mission, vision, and values to align all of our thinking. So we'll talk a little bit about the timeline and how this journey of provider engagement has been created. First, we realized we needed to integrate the group. We had grown from a handful of physicians to more than 80 employed providers, including mid-levels, over a period of about 10 years. These people were scattered all over the city, some not ever setting foot in the hospital. In order to achieve the trust and cohesion we needed to create an adaptable and flexible medical staff that we could most easily lead on this journey, we realized we needed to get them more integrated with each other. We embarked on a plan to get everyone to know each other better and build a culture through social events, altered retreats with more time to talk and learn from each other, mini courses to bring people of like minds together, morbidity and mortality conferences, and the like. The theory was that if the doctors knew each other better, that things would run more smoothly, including through referral pathways. And it worked. After getting the physicians starting to think of themselves more of a cohesive group, we started a multifaceted communication training plan. The DISC assessment was administered, which, as you know, is a communication style assessment, and we used it at 3 separate retreats over the last 3 years, focusing on inter-physician communication, physician-patient communication, and physician-team communication. All of the doctors filled these out and used them and participated in these events, even some of our more subspecialty surgeons. We also realized that in order to continue and advance our cultural development, we needed to find better ways to recruit the type of people we wanted, and ways to retain the stars we already have. We created a recruitment tool that extends from the applicant's first arrival at our hospital all the way into community integration that has worked well. This tool includes specific interview questions that can be covered that tease out cultural fit, plans with intentionality for follow-up with interviewees by physicians and other employees and community members who may be good contacts long-term, and then allows for standard work for onboarding after the physician is hired. I can send a copy of this to anybody else who's interested, but it's beyond the scope of this webinar. We are working on ways to recognize those physicians we already have and those who are going above and beyond in ways that really speak to physicians. And then we come back to communication. This needs to be watered over and over and over in order to keep it living and growing. It's way too easy to let it go. We're also working on inserting the accountability piece as part of our culture to hold each other to higher standards of practice and network and interpersonal behavior. We've realized that allowing some providers to get away with poor behavior was one of the biggest barriers to achieving the culture of collaboration and excellence that we desired. One person not held accountable to our goals and plans poisons the well for miles around. We continue to work on this issue. Once we could tell we had a more cohesive physician group, we decided it was time to start using that power to trim more waste out of clinical operations management and accelerate the journey toward inspired caring by bringing clinical operations and clinical practice together. We changed our bylaws to dissolve the old department structure and reform into medical service lines. Many of you probably serve on a service line like this, as they are attended by physicians, nurses, administrators, lab and x-ray staff, and other clinical support staff as needed. This is starting to result in more on-the-ground or grassroots changes to how clinical operations work, because everyone is in the same room to work on the problems at the same time. Our tactic teams are our newest change. We started this year to integrate the tactic teams into the service lines. We needed the tactic teams to focus on exceptional experience, redesigning care, and ideal culture. It is now becoming very apparent that having those groups exist for their own sake is no longer needed, and we're starting to integrate these tactic team people as well as their leadership style and experience into the medical service lines to really bring these three tactics to the ground level, dissolving barriers between administrative and clinical work. We are creating care-changing teams with more buy-in and the skills to get it done. This takes a huge amount of trust and understanding between caregivers and administrators. Let's face it, we're taught not to work together in school, right? And this step would never have been possible without a cohesive physician group and communication training who was ready to trust and listen to the physicians and the administrators who lead them. So this timeline looks very neat, right? Frankly, this is what the process really looked more like. And sometimes it can feel like this. Let's go back to our engagement survey. Our physicians are by and large very proud to work for us. They feel we have outstanding quality and feel a sense of cooperation and trust in leadership at our network. We have looked for these providers intentionally, fostered these qualities in the providers we already have in very intentional ways, and it's nice to see these results from our physician engagement survey. We've learned some lessons along the way. Achieving an integrated, cohesive, and cooperative physician group dynamic and culture is vital to developing a relationship between physicians and administration that allows for the efficiency and adaptability that is required in today's landscape. Many think this isn't possible with providers, but we can and we must move from talking about it to really doing it. It requires intentionality and energy and resources, but it is well worth the effort. It also requires finding and developing the right physicians and other providers who are interested in helping with this and in leading their colleagues. It is vital to align the goals of the provider group with those of the network. This is important conceptually as well as concretely. Remember those physician council goals I showed you earlier and the tactic teams integrating into the service lines? We no longer have the luxury of having the two groups walk in parallel. Physician, provider, and administrative groups must be married. There have been some challenges along the way. Absolutely, there have been. The service line transition, for example, has not been consistent. One of our smaller service lines, Women's and Children's, was infused with energy and education early on and has transitioned fairly well, but still sometimes functions like its old department self in meetings. Let's face it, old habits die hard. Some of our larger service lines are struggling a little with redefining themselves and with getting enough providers there at meetings to really get a critical mass. We need to figure this out, and we're making some strides already. We've also realized that we need to constantly return to the communication skills training, relationship building, and cultural support, or it starts to die. We need to be trying new things that will be more self-sustaining and take fewer resources of time and money if possible. We need to continually keep this fresh.
We also had lessons learned in the organizational culture work we did as well. We had been very successful in intentionally shaping our culture and aligning our processes and engaging all of our stakeholders at all levels within our organization. That's something that we talked about earlier, and of course it's important to align everyone on the same work that we're doing. We also have done well with focusing on the core competencies in any change process of leadership and organizational learning and development. We offer numerous opportunities and are working regularly with our leaders and high potentials to continue to grow and learn. Of course, we have areas we have not been as successful in and need to continue to work on them. One includes focusing on the why and helping you all understand why improvement, innovation, and change is necessary. This is an area we've been working hard at and are hopeful we have improved in the last several months. We certainly will continue our efforts to explain the why to all of you. Lastly, we need to work on holding each of us accountable to providing exceptional experiences at all times. As Mark has shared, we are not all on our A game every day. But when this happens, we need to back that person up so it is not noticed by our patients and does not have any impact on their experience with us. Leaders need to hold their staff accountable always. That's something that it's essential for us to do. And peers need to hold each other accountable as well. Frankly, it is easier for a peer to see an employee not providing exceptional experience than it is for most leaders. Therefore, we need to continue to work on holding ourselves and each other accountable. Okay, let's talk about lessons learned in system design. The first one is to be open to possibilities, honest about our strengths and weaknesses, and value what we bring to the table. We're a small organization, but we've done fabulous work, and we need to be proud of that. We need to continue to plow the field, continuously engaging stakeholders for challenge, change, and adaptation. We've talked about more with less becomes more through many. That's an important concept that we need to continue to work on. You are what you tolerate, you become what you reward. That's the concept around accountability. We need to reward employees who go above and beyond and are role models, and the ones who are not, we need to hold accountable. And real improvement transcends the delivery system. HFM has built a strong foundation through the work we just shared with you in organizational design, organizational culture, and provider culture. This dedication and hard work from you enables us to continue to focus on providing inspired caring while transforming to the second curve of population health. We have created a solid organization which allows us to interact with the other buildings representing the other factors of population health from the model Mark talked about. This results in us achieving our mission of providing exceptional experiences and services to help individuals and our communities achieve healthier lives. Thank you for your time and attention to our presentation, and thank you all for all you do every day to make Holy Family Memorial the best healthcare provider in the Manitowoc County.